Good evening, ladies and gentlemen. Welcome to another exciting webinar, Secrets of Neurology. As we know, it is a knowledge feast for all neurologists and probably one of the longest running knowledge web series. We have already crossed 1 year of the whole webinar series. Today is 29th of October and we intend to close it by 9:30. A very, very warm welcome to each one of you. At the outset, I would like to give a very warm welcome to our program director, Dr. Sudhir Shah, Professor and Head of Department, NHL MMC and SBPI MSR Ahmedabad. Sir is also Director of Neuroscience at Sterling Hospital, Ahmedabad. A very warm welcome to our program director, Dr. Lakshmi Narasimhan, sir. Thank you for joining despite your busy schedule. We all know him very well, Director and Head of the Department, Professor of Neurology at Institute of Neurology, Madras Medical College. Warm welcome to you, sir. Without much ado, as we have already surpassed our launching time, over to you, sir.
Oh, thank you. And I wish every one of the viewers very, very happy. And today being the World Stroke Day, I wish all of you a very, very happy and lovely neurology career ahead. And today, let's all pledge to take stroke to a higher level. And I request all the young neurologists to become more and more invasive. And can I have the first slide, please? And I apologize for there are some technical glitches. The link didn't work, and then I had to get the link. I apologize for the few minutes delay. My extreme apologies to
Rahul.
Sir, could you help me with these slides? My system is facing a problem, sir.
Yeah, sure.
Sorry, sir.
Is it on?
Yeah, it is on. It is on.
Sure, sir.
And as you know that today's discussion would be by Chinmay. You just start with Chinmay. Chinmay Kumbar, case history will be presented by the resident, and the discussion is done by Dr. Dulari Gupta. Dulari Gupta, I'm very proud that she studied in our institute, and I'm looking forward to her discussion. And welcome to Dr. Dulari. And Dr. Shreya Dole would do the examination and investigation. She's a resident in Deenath Mangeshkar Hospital, Pune, and the whole show is from that institute. And Dr. Rahul Kulkarni is a teacher for all of them. And can I have the slide of Dr. Rahul? Dr. Rahul has done his internal medicine and DM neurology and DNB neurology. He's in association with Matishka Neurology Clinic and Deenanath Mangeshkar Hospital. Areas of interest is stroke, paralysis, epilepsy, headache, migraine, backache, neck pain, disc nerve problem, Parkinson's. And tropical neurology is very active, and all of us know his contributions in the field of neuroinfections, dengue, and now Mucor, and also he had his contributions in COVID. Outstanding clinicians and my very good friend. Looking forward to your show. Over to Dr. Rahul Kulkarni for further things. Thank you.
Thank you, Lakshmi sir, for these kind words. Welcome everyone. Today being a World Stroke Day. Last time we discussed with Dr. Lakshmi as well and Dr. Sudhir Bhai whether we are going to show a stroke case, but I must tell you that we are not showing a stroke case. We had a lot of strokes since morning. So this is a non-stroke case that we are showing. So I think we'll start. We have lots of points where there is a break for comments and interactive discussion. So I would request even the panelists also and the attendees also to raise their hand and they can discuss. They are free to discuss at any point. We have kept ample space for everyone to discuss. And we want more and more discussion in this case. So I think we'll start the case. We'll start with the history. Over to you, Dr. Chinmay. Normally, we know that in presentation, we always have the history of present illness, and then you go to the past history, personal history, and the present history. But this patient has a little unusual history. So we would start from the past, which is not very past. So over to you, Dr. Chinmay.
Thank you, sir. So as Dr. Rahul sir said, we'll be starting with the past history. Our patient is a 33-year-old lady with a past history of joint pain for the past 6 months. She is complaining of generalized pain for the past 6 months, skin rash for the skin rash 5 months ago, which lasted for 1 month, and vomiting on and off for 1 month, which has worsened over the last 15 days. So elaborating on the joint pain, she had small and large joint pain involving both the arms and legs with right wrist and elbow joint swelling. There was no waxing and waning of the joint pain. There was no overlying joint redness, no early morning stiffness, and no restriction of range of motion. Regarding the generalized pain, it was a diffuse pain predominantly in both the thighs and arms. There were no cramps or contractures. Patient had difficulty in ambulating due to the pain. There was no history of high colored urine, no thinning of limbs, no dysphagia, diplopia, or ptosis, and the patient had received NSAIDs for the same. The patient had a skin rash 5 months ago. This rash was associated with fever, joint swelling, and pain with myalgia. The skin rash was present all over the body. It was maculopapular erythematous and without any pruritus. There was no photosensitivity phenomenon. The rash had worsened with sulfasalazine due to query sulfa allergy. There was no history suggestive of mouth ulcers, breathlessness, or pleuritic chest pain. There was no history of frothing of urine, periorbital swelling, oliguria, or hematuria. These are the pictures of the rash the patient had, which looks erythematous and maculopapular on the face. On the left side, we can see there's a swelling on the hand, on the dorsum of the hand, and joint swelling of the metacarpophalangeal joints as well as the interphalangeal joints. Regarding the vomiting, patient had multiple episodes of vomiting for 1 month, which had worsened over the past 15 days. The vomitus contained undigested food, there was no blood, and the vomiting was non-projectile. Her upper GI scopy was done, which showed antral gastritis. There was no history of headache, diplopia, or any symptoms of raised ICD. Regarding her past medical investigations, her RA factor, anti-CCP, ANA, and HLA-B27 was negative. CPK was done in the range of 1000, and EMG, skin, or muscle biopsy was not performed. She was treated by a rheumatologist as polymyositis with arthritis. She had received injectable methylprednisolone single dose, and then she was switched to oral steroids with methotrexate, but methotrexate was stopped in view of gastritis. So she was taken on oral steroids, that is prednisolone, 10 milligram per day. The pain had improved partially, and the patient was ambulating with support till she presented to us with sudden worsening of the weakness. There is no history of addiction, no history of consumption of any alternative medicines, no significant family history, and no similar episodes in the past. Her last menstrual period was 15 days ago, and there was no history of recurrent abortions. On presentation to our institute, she complained of bilateral lower limb followed by upper limb weakness over the last 3 days. The patient had altered mentation for the past 3 days, and she was unable to pass urine 1 day before admission. Regarding her limb weakness, the patient had developed initially difficulty in walking, getting up from squatting position, and then developed slapping of feet a day later. This weakness progressed to involve the upper limb over the last 3 days. Initially, patient was unable to lift arms overhead and then developed difficulty in buttoning and unbuttoning over 12 hours. It was associated with pain in both thighs and arms. There was no muscle twitching, and history of sensory loss could not be documented because the patient had altered sensorium. Regarding her altered sensorium, the patient had altered mentation since the last 2 days before admission. There was increased drowsiness, but no agitation. The patient had crying spells, which was maybe due to severe pain which she was having, and there was no history of fever or seizures. The patient was also not able to pass urine since last 24 hours before admission. It was associated with abdominal pain and needed urinary catheterization in the emergency room, and large volume of urine was drained. The patient did not have any bowel complaints. So to summarize the history, our patient is a middle-aged lady with 6 months history of asymmetric polyarthralgia and severe generalized pain. The patient had recent worsening with vomiting, altered sensorium, and acute symmetric painful quadriparesis with urinary retention. So to localize the quadriparesis, we would localize the disease to any muscle disease. a peripheral neuropathy, a spinal cord lesion, or a cerebral etiology. Regarding the etiology for the altered sensorum or encephalopathy, our first differential would be connective tissue disorder like SLA neuropsychiatric manifestations, vasculitis, or PRES. Second etiology would be any ADEM-like disease, and third would be any opportunistic infection causing encephalitis owing to a history of immunosuppression with methotrexate and long-term steroids. So we would invite any comments.
So would anyone like to comment about from the history part as to what do you think, what anything you think should be done or can be seen when you examine the patient? Any comments from the history?
So, sir, we have Dr. Jay Chaudhary. Can we allow him into the panel?
Yes, yes, of course. You allow everyone whosoever wants to answer or ask
I think
question.
Dr. Jay, sir, you can unmute. Yeah.
Yes, ma'am. Yes, ma'am. I want to ask about any history of fever was there or not?
Chinmay, do you want to answer that?
There was no history of fever. There was no history of fever.
Okay, thank you. Thank you.
So basically, this was a lady who presented with initial symptoms of generalized pain. When she was investigated, her CPK was found to be high and she was treated as polymyositis with arthralgia by a rheumatologist. And now she has presented with 3 days history of weakness followed by progressive encephalopathy and the persistent pain. And then of course, she also has developed vomiting since last 1 month. There is no history of any fever. So that's the case that we have.
Eli, Dr. Vibhor Upadhyay wants to say something. Vibhor.
Vibhor asked whether there is meningism. Of course, we are yet to examine the patient. Vibhor, you want to ask anything, Dr. Vibhor?
Vibhor, sir, you can unmute and you can have an interaction, sir.
Just sir, wanted to know about the history of infection, fever history associated with meningismus sign.
No fever. Patient did not have any fever.
Yeah.
Patient did not have. She had vomiting, of course, but there was no history of headache.
Okay.
Does anybody want to comment exactly where they would anatomically localize the cause for the present state of the patient?
Only from the basis of history.
Yes.
Dr. Kailash wants to ask whether there are any visual symptoms. Patient did not complain when she came to us. Of course, we'll come to the examination and the finding and the course of the illness where there may be something. And then any sensory or cranial nerve symptoms. There were no cranial nerve symptoms from this much of history that we got when she got admitted with us. Of course, as far as sensory is concerned, she had a lot of pain, but there was no tingling as such. And Dr. Smriti says that brainstem vomiting is presumed to be central in origin. Okay. Do we go towards the examination findings?
Dr. Kulkarni, can we ask Dr. whoever she said why she thinks brainstem, why she immediately gets into the brainstem? I would like to know.
Dr. Smriti.
Sir, should we take her into the panel?
Yeah.
Yes, please.
Smriti ma'am, you are into the panel. You can unmute and you can interact, ma'am.
What makes you think that, Dr. Bose?
Yeah, there is encephalopathy and there is quadriparesis. If you have to put all of it together with a possible, I mean, if we go by the Occam's razor and presume that the vomiting was because of a central cause, then base of fourth ventricle, area prostrema causing the vomiting. it could be around that area. The quadrilateral is encephalopathy because of the reticular activating system and everything else together.
Okay.
Dr. Bose, can I just ask you that this lady had severe pain, a kind of rash, and followed by some weakness. It seems moderate weakness and just some altered sensorium.
This
So-
is just, yeah, this is me just trying to anatomically localize the neurological aspect of it. There must have been a previous rheumatological onset, eventually leading to an autoimmune cause, which needs to be further evaluated on examination. But keeping all options open, neurologically, if we have to localize at the highest point, it would have to be the brain. It could be the brainstem is what I was trying to suggest. I'm not saying that there is no rheumatological problem or SLE in the background, but neuroaxis involvement, uppermost level would be this based on whatever we have.
Very good. Very good.
Thank you.
Dr. Kulkarni?
Yeah, I think we'll go ahead. Thank you, Dr. Smriti. So I think we'll move towards the examination findings, and I would request Dr. Shreya to start the findings.
Good evening, everyone. I'm Dr. Shreya Dore. I would be presenting the examination findings and the investigations in our patient. So our patient had stable vitals with heart rate of 80 beats per minute regular, BP of 100/70 millimeters of mercury, no cyanosis, clubbing, lymphadenopathy, no rash or oral ulcers were seen. There was left lower limb pitting edema. There was generalized tenderness all over the body, and she was crying incessantly even during the examination process. She had to be catheterized, and there was no joint swelling or deformities that were noticed. In neurological examination, her higher mental functions, she was drowsy, arousable with GCS of 11 out of 15. There was no neck stiffness, no extraocular muscle restriction. However, her vision could not be assessed very well. She was crying and not cooperating for examination. There was no relative afferent pupillary defect. Pupils were equal reacting to light. There was no papilledema noticed on fundoscopy. On motor examination, there was no wasting, tone was normal. Due to pain, the motor examination was restricted. However, it was up to 2/5 of power in upper and lower limbs proximally as well as distal. The deep tendon reflexes were 2+. Plantars were bilaterally extensor. Abdominal reflexes were absent. No involuntary movements were noticed, and gait and sensory could not be assessed satisfactorily because of the altered sensorium. So here in a nutshell, our patient is a middle-aged lady with 6 months history of asymmetric polyarthralgia with generalized pain. She is presented with recent worsening with vomiting, altered sensorium, and acute onset symmetric quadriparesis with urinary retention. She had severe pain. The reflexes were retained on examination, and extensor plantars were noted with no neck stiffness. Now, I would like to ask where we are localizing. So the differentials that we put for localization were as follows. It could be a muscle disease, peripheral neuropathy, spinal cord involvement, cerebral involvement. Now, what are the points in favor of a muscle disease? Patient had generalized pain, could be a part of myalgia. She had pure motor quadriparesis, sensory was not apparent. She had elevated CPK level in investigations done elsewhere. She's been on steroids for around 6 months. So that was also possible that she had some steroid-induced muscle involvement or muscle disease. She had some rash earlier. It's a middle-aged female. Possibility of connective tissue disorder needs to be considered. There was rash, as I had mentioned earlier. However, we cannot explain the encephalopathy or urinary retention on the basis of muscle disease. And for a muscle disease to worsen this rapidly within a span of 3 to 4 days is odd. Localizing to peripheral nerves, The points in favor are severe pain in the limbs, could be neuropathic in origin. Associated connective tissue disorder does point to peripheral nerves because we can have vasculitic peripheral neuropathy, or there could be mononeuritis multiplex, which has now progressed to involve multiple nerves, peripheral nerves. However, again, bladder involvement and encephalopathy is not being explained. And we had retained reflexes in this patient, which would not be expected in a case of peripheral neuropathy. Now, moving on to spinal cord. Quadriparesis with urinary retention, yes, possible with spinal cord. Extensor plantaris are in favor as well. However, encephalopathy and normal reflexes is odd for spinal cord. There were no frank myelopathic signs in our patient. We were not able to assess for sensory involvement or any sensory level. Cerebral involvement is possible because there was altered sensorium and extensor plantaris, like we said, brainstem and cortical multifocal disease. The urinary retention is odd for involvement of cerebral origin. In cortical involvement, we would have expected hyperactive spastic bladder with urge incontinence. However, she presented with painful abdominal urinary retention. The quadriparesis is also a little odd for cerebral involvement, and the pain, which was severe and which hampered the detailed clinical examination, was a constant. So etiologic differential diagnosis, I would like to keep it at SLE with overlap syndrome with polymyositis, with neuropsychiatric manifestations, or a possibility of posterior reversible encephalopathy syndrome or PRES. Acute demyelinating encephalomyelitis or EDEM, as we had discussed earlier, is a strong possibility. I would also like to consider steroid-induced myopathy along with Wernicke's because of the excessive vomiting or metabolic derangements which have caused metabolic encephalopathy. However, for this third differential, the tempo of the illness and duration is odd. The worsening is relatively fast or acute. Now, I would like to move on to the investigations. Her hemogram and liver function tests were normal. In urine routine, there was no proteinuria. Electrolytes were normal. However, her urea was raised to 208 and creatinine was 3.38. We had repeated her serum CPK levels, which were 378. Her HIV ELISA was negative. Because we were considering connective tissue disorder, thorough workup was done. C-ANCA and P-ANCA were negative. ANA by immunofluorescence was negative as well. However, in the ANA blot, we noticed borderline positivity in MI2, KU, CENP-B, and AMA-M2. Now, these are the antibodies which have significance as follows. MI2 and AMA-M2 can be present in cases of myositis. KU can be present in scleroderma polymyositis overlap, and CNP-B and KU, both if positive in higher amplitude, will point towards systemic sclerosis. Patient underwent lumbar puncture and the proteins were 88, slightly elevated, glucose 59, and one nucleated cell was found. Her USG abdomen did not show renal involvement. Nerve conduction studies showed sensory neuropathy in the lower limbs. EMG did not show any features of myositis. Now moving on to the imaging. In MRI brain flare axial images, we can see bilateral flare hyperintensities which are present in the temporo-occipital region, which are more on the left side as we can see here. And on the image where we are seeing the cross-section at the level of basal ganglia, there is a gangliocapsular flare hyperintensity, which has been marked by thick arrows. We can see left thalamic medially, we can see hyperintensity on flare axial images as well. Now the same lesions we can see on sagittal section, where we can see the thalamic hyperintensities on the axial section as well. Now these same lesions on diffusion weighted imaging had shown restriction, which is seen in the temporo-occipital region on the left side, basal ganglia, and in the corpus callosum also, in the genu. However, there was no enhancement on T1 contrast imaging. Now here I would like to invite any comments, especially on the basis of the imaging findings.
imaging it, go back. Imaging it showed a lot of findings. So if anyone could comment, if anyone wants to comment anything of the investigations, the imaging findings. Okay.
Rajarshi, Chakravarti and Swati want to comment. Heli, can you take Rajarshi Chakravarti, Hashir Malik and Swati?
Yes, sir.
And Jay is there already. So Swati, you want to say something? Rajesh?
Yeah, there is lentiform fork sign of metabolic acidosis seen in the flare, and some features of press bilateral posterior predominant changes in the flare sequence. The lentiform fork sign basically is of metabolic acidosis. It can come in uremic encephalopathy also.
Patient did not have high blood pressure anytime during the course, right, Dr. Shreya?
Yes, sir. The blood pressure was 100/70 millimeters of mercury.
Swati and Hashir.
Dr. Hashir says same thing, lentiform fork.
Yeah.
Yeah.
Vibhor wants to say something.
So they are inside panel.
Yeah, I know he's in panel. And yeah, and Dr. Prabhu as well. He wants to say something. Dr. Prabhu. And
speak up, don't want to speak because this is more of an interactive kind of meeting.
Yeah, absolutely. Dr. Dole, Shreya wants
Dr. Swati says Ripples. Dr. Rajeshri says lentiform fork. Dr. Vibhor says wishbone sign. Dr. Prabhu says MRI spine and encephalomyelitis. And Dr. Kailash says whether spectroscopy was done.
So Shreya?
Yeah. Yes, sir. So MR spectroscopy was not done. And lentiform fork sign, yes, we can see it on the flare hyperintensity. MRI spine, I would like to reveal it a bit later.
Dr. Shreya, she said oblique mob.
Yeah, so Shreyashi, Heli, just let's take Shreyashi. Let us hear why she wants to put these differentials. Dr. Jha?
Anyone who want to talk, I mean, you're free to talk. Dr. Shreyashi, Dr. Kailash, Dr. Prabhu, Dr. Vibhor.
Oh.
Yeah. Heli, I don't know whether you included Shreyashi.
Yeah, she's here.
Sir, she's there.
She's joined.
Yeah.
Prabhu also joined. Yeah.
Yeah, but connectivity, your connectivity is poor.
She's not connected properly. Dr. Shiva Kumar wants to ask whether MRI spine was done. Yeah.
So a lot of them want to know.
Probably, I think Dr. Shiva, go ahead.
Dr. Kulkarni, can we just ask all of them who wanted a MRI spine in spite of such florid findings, why does everybody think a spine?
Yes. So why extra MR spine was needed?
So much we have in the brain, don't we?
And then probably there is a neuropathy also. The CPK was also on high-ish.
So what makes everybody think of spine?
Hello, sir.
Yeah, go ahead.
Yes, sir. By MRI brain, we cannot explain the other findings present in this patient, like severe body pain. Also, the extensor plantar. Okay, it can occur both in cerebral as well as spinal involvement, but urinary retention is there. And so this much of finding, if it is present both in cerebral as well as spinal, whether the disease process is involved in both the cerebral as well as spinal, we want to know.
Okay.
And whether visual VEP was done in this patient.
Initially, she was too restless and she was not in a position to sit. She was crying, as Dr. Shreya said. Even while touching, she was not allowing us to examine because she was having severe pain. She was not able to sit, and she was in encephalopathy. So, eye-to-eye contact also was a bit difficult. Dr. Shreyasi says that gray matter and subcortical white matter because she's got disconnected. And Dr. Sumit Kumar says that whether it is JE.
So Dr. Kulkarni, what are our thoughts that she's saying that because there is involvement of both gray and subcortical white matter, this goes right directly into a mock disease rather than anything else.
True. So let's go ahead with the further finding. Let's go ahead.
Sir, anything in optic nerves in MRI?
Question. The first MRI, Dr. Kailash, Shreya, you want to answer this?
Yes, sir. In the first MRI, there was no enhancement or flare hyperintensity in the optic nerve.
Anything in the diffusion in optic nerves?
No.
Okay, thank you.
Of course, we didn't give contrast because patient had deranged RFTs, right?
No, we did a contrast.
Okay.
However, it did not show any enhancement, neither in the optic nerve nor elsewhere.
Okay. All right, go on.
Yeah. So now I would like to discuss the differential diagnosis based on the imaging. We have almost discussed most of them. So the first finding is of cortical or subcortical white matter temporoparietal hyperintensities. These could be a part of PRES or ADEM-like presentation, and vasculitis can have similar presentation. However, territorial involvement was not seen. Now for PRES, the odd point is that the patient had BP which was persistently around 100/70 or 90/60. There were periventricular subcentimetric T2 hyperintensities seen, and the lesions were restricting on diffusion, especially in the genu of the corpus callosum. Now this is possible that it is a demyelinating pathology which is causing this involvement. And we have discussed the fork-shaped T2 flare hyperintensity with diffusion restriction, which is the classic uremic fork sign, which we have already discussed. It's a part of metabolic derangement. The patient has undergone nerve and muscle biopsy. Sural nerve did not show any abnormalities. Peroneus longus muscle biopsy had shown mild inflammatory myocytic findings. Now coming to MRI spine, which all of you are waiting for. So the MRI spine has shown on the cervical imaging, we can see over here that the hyperintensities are extending from medulla up to the cervical cord from C2 to C5. There is no cord expansion that is noticed. In the thoracic cord also some flare hyperintensities which are seen, and in the lumbar cord you can see a few flare hyperintensities. They are not very obvious that are seen over here. On the axial imaging of the MRI spine, we can see a central lesion which is covering almost whole of the spinal cord, which is seen on the flare imaging. Now further, her sensorium had improved with correction of uremia over the next 3 to 4 days. This is where she volunteered the history of blurring of vision. Her bedside vision assessment showed left eye vision of perception of light and projection of rays, that is PLPR positive. In the right eye, her finger counting was possible at 1 meter distance. However, no relative afferent pupillary defect was still noticed, and fundoscopy did not reveal any abnormality. The patient continued to have severe myalgias, pain, quadriparesis, and she still needed urinary catheterization. Now looking at the MRI spine and the clinical features, I would like to invite any further comments.
Dr. Kulkarni, there are some who have put in more differentials. Jay has put Lyme Behçet's. One, I think Rajesh has now revised it to MOGAD. And yeah.
So there are some differences which have been put up for the brain finding, but now we have something in the spine as well. So considering the brain as well as the spine finding and the clinical history and the symptomatology, what anyone wants to comment anything?
Yeah, Jay Chaudhary wants to say Lyme-Behcet's. Is it truly possible in this scenario? Putting all together.
Basically, we have a lesion in the spine, which is probably a fairly large lesion like LETM. And then, of course, we have, yes, so Dr. Ashir Malik says that MOGAD with area postrema. Dr. R.K. Garg, sir. So, Garg, sir, do you want to say something?
Dr. Garg?
So, Haley, can we take Dr. Garg in?
Yes, sir.
Can such a, until sir is coming in, can Lyme and Behcet's cause this kind of a LETM? And can MOGAD have? Yeah.
Can I speak?
Yes, sir. Yes, sir. Go on.
Yeah. To me, as far as brain is concerned, all the features, imaging features and clinical features as well, to me, it looks like a uremic encephalopathy. And these spinal cord lesions, this hyperintensities, if you keep everything together, then to me, vasculitis leading to uremic encephalopathy.
Okay.
Now, okay, it's possible. Dr. Kulkarni?
Yeah.
MOGAD,
yeah.
Putting it, is it possible to put everything together with MOGAD?
The pain was a bit odd for MOGAD, I must say. And then the initial history of probably rheumatological disease or arthropathy was unusual finding for a MOGAD disease.
Absolutely. 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 So Shreya, can you just answer Vibhor, say any history of seizure and were optic nerve normal in MRI?
Sorry, I didn't get you, sir.
Were optic nerves normal in MRI and was there any history of seizure?
Yeah, so there was no history of seizures, and the optic nerve on contrast MRI and on FLAIR, there was no enhancement seen.
Okay. Shall we go ahead?
So this means patient had cortical blindness.
That is a possibility, sir.
But now that her sensorium improved and you were able to perform a decent formal optic nerve examination, it appears that there was very poor vision, poor visual acuity in the form of finger counting at 1 meter. So, and perception of light. So it is possible that anterior visual pathway could have got affected. Dr. Kulkarni, you want to comment something on this?
What about pupils?
But the pupils were equal and there was no RAPD.
This means anterior afferent pathways are correct and the lesion lies in the brain, cortical blindness.
Possible.
There is a difference. The left eye showed that there was just PLPR present, and the right eye, it was 1 feet. So there was little asymmetry in the both eyes.
There was a profound impairment of acuity. But of course, we had bilateral occipital lesions. Yeah. So actually, with no pupillary involvement, but if the vision had to be symmetric, both affected equally bad, then we may not have had the afferent pupillary defect. Dr. Kulkarni?
Yeah. And she was not in a position to sit so as to do visual evoked potentials or maybe even perimetric examination.
OKN was one thing. I don't know whether we did. Shreya?
No, sir, we have not been able to do. She had pain and she was not cooperating.
Yeah.
Yes, sir.
Okay.
And of course, the antibody question has been there, aquaporin and MOG antibody. EEG was not done. Angio, we did not do angio.
No.
This lady. Angio was not done.
But a contrast was available. So if there was any significant bleeding or something, contrast was there for us to have. Okay.
Yeah. So Rajesh says MOGAD can lead to such severe blindness with LETM. Yes.
NMOSD. NMOSD.
Yeah.
Okay.
Screening for infection. Dr. Prabhu wants to ask whether there was screening for infection which was done. Of course, there was no fever, there was no meningism. The CSF did not show a lot of cells. So we did not think infection first in the list.
Yes, sir.
Yeah.
So the findings are more in favor of both the cerebral as well as cord involvement, but the myalgia, severe myalgia, which we could not explain otherwise. Even with if you consider a NMOSD or MOGAD, there is nothing reported like a severe patient presenting with severe myalgia and this altered sensorium. So sorry, altered sensorium can occur, but the severe myalgia is what we want to narrow down the diagnosis. Either it could be a infectious or vasculitis like that we want to rule out.
Okay. So do we move ahead? Any other comments? Anything else?
Dr. Kulkarni, Dr. Shreya writes that hypercemia can be a part of NMOSD.
And myopathic paralysis well.
Can occur, a myopathy-like presentation.
Yes.
And obviously,
Dr. Apus said that coexistent NMOSD with connective tissue disorder.
Connective tissue.
Very nice. Okay.
Very nice. Okay.
Well taken. Okay. Go on. Dr. Shreya, go on.
Yeah. So her aquaporin 4 antibodies were positive. MOG antibodies were negative. Her VP showed bilateral prolonged P100 latencies suggestive of anterior optic pathway involvement. She was treated with IV methylprednisolone 1 gram over 5 days. Her pain had reduced with it, but not disappeared. Her upper limb power had improved to 3/5 from what it was earlier at 2/5. However, there was no change in the lower limb power. She had to undergo plasma exchange 5 cycles for the same because she was non-ambulatory till then. At discharge, she was alert oriented and the vision had improved to finger counting at 2 meters with both eyes. Pain had improved. She was comfortably sitting up. Truncal weakness had improved. Upper limb power was at 3/5. However, lower limb persisted to be at 2/5, both proximally and distally. The bladder did not improve. She had to be discharged with urinary catheter in C2. Now, this is the time which is followed up with us 6 weeks later. She's alert oriented, no pain. She has tachycardia and diaphoresis. In vision examination, right eye finger counting at 2 meters, left eye finger counting at 2 meters with relative afferent pupillary defect now being obvious. And disc pallor is seen on fundoscopy, which is more on the left side than right. There was no wasting, tone was normal. Power was 3/5 in upper limb as well as lower limb. Reflexes are 2+, plantars extensor, and she has sensory paresthesias all over body. We have repeated her imaging. MRI spine, which is repeated, is showing this spotty bright lesions, which you can see in the cervical cord and the dorsal cord, which is seen on FLAIR. These lesions are enhancing on contrast administration. And the MRI brain had shown some leptomeningeal enhancement in the occipital region. 6 weeks later, post-contrast FLAIR is also showing persistence of few of the press-like lesions that we had seen earlier. Patient has received tapering dose of oral prednisolone, and we have given her the first dose of rituximab, 1 gram. I would like to invite any comments on this.
Dr. Harshir wants to say why RAPD was not appreciated in the first admission examination. I thought that the vision loss was more symmetrical initially, which did not cause RAPD, and now the improvement probably was a bit asymmetrical, which led to RAPD. That's what I think. Dr. Kulkarni, you have to unmute.
Sorry, it's a possible that initially there was a cortical blindness, and during the course of the illness, she would have had developed optic nerve involvement, which was seen in the second MRI, which had shown that left optic nerve was enhancing, which was not there earlier. So probably the vision loss was because of both the cortical involvement, the cortical blindness, and later during the course of the illness, probably she would have had developed optic nerve involvement during the course of the illness. Anyone else wants to comment, or we go ahead? Garg Sahab, any comments?
Dr. Chakravarti says why there was no optic nerve changes in the MRI. Optic nerve has a limited.
Second MRI, the second MRI had shown that the left optic nerve was enhancing. First MRI did not show it, but the second MRI, the one which is being shown just now, had a left optic nerve involvement. We will show probably an image. Do we have image here, Shreya, or it is later?
No, so it will be there in the subsequent slide.
There
is optic nerve, subtle enhancement.
Yeah.
And leptomeningeal enhancement, is it possible to? I thought that it is a delayed leptomeningeal enhancement in the area where there was press.
Yeah.
Otherwise, the aquaporin 4 disease really, we do not expect a leptomeningeal enhancement. It is more towards MOGAD.
Then primary CNS vasculitis, the odd point is now we have optic nerve involvement also in this patient, so which is very unusual for a primary CNS vasculitis, and especially that in the early team there. There's a question about how early rituximab was started. Rituximab was started within 4 weeks. Initially, after steroids, she was given plasma exchange, and within a month's time, first dose of rituximab was given. Of course, there were financial and other issues also. Yes. And then Dr. Malik says something. Dr. Pujari, you want to comment?
Yeah, see, so Dr. Malik says that the pattern of optic nerve enhancement, we can decide between MS, NMO, and MOGAD. Very interesting thing. Perfect. Very well said, Dr. Malik. Malik, would you like to tell all of us how it helps? You can come in and volunteer. Ashir?
Haley, can you take Dr. Malik in, and then let's take the comments?
Yeah.
Because it's a very interesting point that he has mentioned.
Yes. Very important point. Each organ involvement can differentiate one versus other. It's a very useful chart nowadays when we teach one of demyelination and try and differentiate one from each other. Dr. Malik, are you there? Yeah. Do you want to tell everybody?
He is there.
Yeah, he is there. Dr. Malik? I think it's still.
Yes.
Yeah.
Are you able to hear me out?
Yes, yes.
Yes, please go on.
Basically, in the NMOST, it is mostly bilateral, and it involves the length like latem is observed in the spinal cord. It is long track involvement, means the length of optic tract is involved, extended from the and in MS it is mostly unilateral, and I'm actually not good at it because I have not revised that table I was talking about, but as I remember, there is a difference based on the imaging findings in the three of them. I would like
Perfect.
someone to correct me on that.
Perfect. You said it right. So posterior optic nerve involvement and chiasmal involvement in NMOSD.
In LETM, we have a term which is called as LEON here.
Yeah, LEON. There is an echo. And again, bilateral optic nerve involvement again in MOGAD, but not as long, like Dr. Kulkarni said, and unilateral, both retrobulbar as well as papillitis seen with MS. So this is how we differentiate. And perioptic nerve enhancement.
Yeah, Dr. Shreya, she says same thing.
Yeah,
Retrochiasmatic
Dr. Zah, perfect.
Anti-recess and she says perioptic. Yeah, so
Perioptic. Perfect. Perfect.
So we know that looking at the MRI of the optic now, one can differentiate whether it is MS, NMO, or MOGAD. Point well taken. Yeah.
What
I think we'll go ahead.
Dr. Kulkarni, can we ask the audience the history of arthritis, arthralgia, rash, and the kind of pain? Does it in any way help us to pick up between vasculitis, MOGAD, and NMOSD? You think that's relevant to discuss?
Yep.
So what does the audience want to say? We are all putting our money on these three, but which is the right one? Vasculitis, MOGAD, and NMOSD. Does the arthritis, rash,
the previous illness for which the patient was treated, there was raised CPK, then there was some arthralgias, there was the rash.
Absolutely.
And she was treated with steroids as well as methotrexate.
Dr. Chaudhary, yeah. Dr. Chakravarti, you said it. Vasculitis can be SLE. Dr. Surendra Kumar, Heli, do you want to take Dr. Surendra Kumar in? Let him comment on what his opinion is what his answer is on the question that we raised.
He is in.
Yeah, good. Dr. Surendra Kumar, you want to say? You can unmute and discuss. Great.
My video is visible?
No,
you are audible.
But you are audible.
Okay. So it can be the possibility of vasculitis can be associated with animal spectrum disorders as well.
Absolutely. And SLE also you said, yeah. So one of you said SLE.
Yeah, SLE, many a times SLE is associated with some features of SLE are present in animal also.
Absolutely. Guru Prasad, you want to say something? Guru Prasad is here.
So he is also
Dr. Sumit says that peripheral neuropathy. What percentage there is NMOSD and peripheral nerve is not involved in MOGAD?
Hello, sir.
Yeah,
go on.
Guru Prasad?
Yes, sir. Sir, since patient is not improved with treatment and patient has skin rash and with CPK elevation and optic nerve involvement also mentioned in primary CNS angiitis. So I'm more towards primary CNS vasculitis, sir.
But the question we would like to ask is such bilateral optic nerve involvement, LETM, a positive aquaporin 4 antibody, and then none of these serological markers for vasculitis positive.
Yes, sir. Yes.
How would you add them to the story?
Yes.
Guru Prasad?
Yes, sir. NMOSD aquaporin 4 positive we can't explain with primary CNS angiitis, sir.
But if we go the other way around and consider, we know that aquaporin 4 antibody has a good specificity.
Yes.
It is not like ANA where it can be positive in other diseases such as with MS. It can sometimes be positive. It never happens with aquaporin 4. So if
Yes,
we
sir.
begin with aquaporin 4 and trace back the situation of the illness, then probably what Dr. Surendra Kumar says would be more plausible.
Yes, sir.
And
Okay.
false positive aquaporin probably is not been reported.
Not very
Yes.
common.
Yes, sir.
Yes.
And Dr. Shreyashi says that follow-up MRI clearly shows bright spotty lesions, and NMOSD can be having high morbidity even with treatment. So agreed. So the patient had presented with quite a few findings on imaging clinically as well as radiologically, and it was clear that this was a very severe attack of NMOSD. If you say that this was an NMOSD attack, and obviously she had not responded well to the available therapy. So we know that NMOSD relapse or an attack has bad prognosis many times. This was probably one of the severe kind of attacks. So the poor recovery may not go against NMOSD in this patient. And
Dr. Kulkarni, I just want to raise one point. The image that Shreya has just displayed, contrast MRI, contrast lens-like involvement number 1, and obviously we all know the lesion extending to area postrema, another strong feature, and the medial thalami diencephalic lesion, not the other ones which were looking like.
Later. We are showing some images.
And so those are the also ones that NMO.
Plasmapheresis was, of course, offered. Dr. Surendra Kumar said. There's a question about neuropathy. How do you explain the reduced snaps in this patient? So the patient had probably associated connective tissue disorder. So there is a chance that patient may have had a neuropathic involvement, also peripheral now. And we had done a nerve biopsy, which did not show much of inflammatory involvement. JC virus, whether JC virus was sent, we did not think of encephalitis in this lady. So JC virus was not sent. Okay, I think we'll move on to the next session. So about some discussion about the case and further things. So I would request Dr. Dulari to come up. Dulari, are you there?
Good evening, everyone. Can you see my screen and can you hear me?
Yes.
Okay. I'd like to thank Dr. Kulkarni and the organizers for allowing me this opportunity, and especially Lakshmi Narasimhan sir, who's my teacher and mentor. So I will have some points that we learned and discussed from this case. This was a case of aquaporin positive NMO, and we know there are 6 core defining features of NMO, and this patient seemed to have 5 out of those 6. Also, pain as a presenting feature of NMO was something that we learned from this case. Also, the presence of press-like lesions in NMO and the coexistence of both NMO with connective tissue disorders. So according to the International Panel for NMO Diagnosis 2015, the presence of a positive aquaporin 4 antibody with one of the 6 core clinical features would define a case of NMO. And the 6 clinical features are optic neuritis, acute myelitis, area postrema syndrome with or unexplained vomiting and hiccups. These are the core features. The less common ones would be an acute brainstem syndrome, narcolepsy or acute diencephalic syndrome with diencephalic involvement in the MRI imaging, and symptomatic cerebral symptoms suggestive of NMO type of brain type lesions. So our patient was unusual in the fact that in the first attack, she had 5 of these 6 core features. And the first slide, I will show you bilateral medial thalamic lesions. She had altered sensorium and she had these lesions. So we place that as a diencephalic syndrome. In the second slide, we show you press-like lesions and cerebral involvement seen in NMO. In the third one, we show LETM with longitudinally extensive myelitis. In the fourth one, that's also an imaging of the spine, and in which you can also see the LETM extending up to the medulla and also involving the area proxima. And in the fifth one, you can see enhancement of the optic nerve, especially on the left side. So our patient presented in her first attack of NMO with 5 out of the 6 core characteristics for which define NMO syndrome. Pain in NMO. In fact, the very first patient described by Devik and Eugene Galt also had severe neuropathic pain. And the first statement that pain is sometimes so strong that it causes the patient to cry is actually a description of their patient from the first case of NMO that was described. So overall, pain is very common in NMO, and more than 80% of patients have pain. And in about 50%, an increase in the severity of pain could be an indicator of a relapse. In a 1/4 of patients, pain might be their worst syndrome. And about the pathogenesis of this pain, a loss of aquaporin leads to accumulation of glutamate. This is an excitatory neurotransmitter. There's an imbalance between the GABA, AMPA, and the glutamate, leading to increased excitatory neurotransmission, and that facilitates the development of neuropathic pain. So pain in NMO can both occur in the acute setting as well as in a chronic setting. So in the acute setting, it could be because of optic neuritis related pain, pain on movement of the eyes, could be headache or neuropathic pain. In the chronic setting, it could be intermittent neuropathic pain, permanent neuropathic pain, spasticity related pain, painful tonic spasms, or chronic back pain. NMO has been known to coexist with connective tissue disorders. And SLE is seen in about 53%. Sjögren syndrome is seen as about 17%. It's very important to know that NMO is not a complication of connective tissue disorders, and no one really knows which disease comes first, but their coexistence is very well documented. So other systemic autoimmune disorders which are connected with NMO can be rheumatoid arthritis, sarcoidosis, APLA, ankylosing spondylitis, and also systemic sclerosis. Other organ-specific autoimmune disorders like myasthenia gravis, autoimmune encephalitis, celiac disease, type 1 diabetes can also be associated with NMO spectrum disorder. Now, this is a Chinese study which compared patients with NMO who had connective tissue disorder versus those who did not have connective tissue disorder. And in this, they found that patients with NMO who had connective tissue disorder had higher levels of IgG, longer spinal cord lesions, less likely to have short segment transverse myelitis, and on T1 hypodensity on MRI was more prominent, and they had more T2 bright spotty lesions on the MRI. So this is on repeat at 6 weeks when our patient visited us again. This was her repeat imaging, and on the sagittal T2 stir of the spine, you can see that there are multiple discontinuous lesions in the cervical region going up to the medulla and throughout the cervical region and almost throughout the entire thoracic going down to the lumbar region. There are these multiple bright spotty lesions. The presence of these bright spotty lesions in a patient with NMOSD is more suggestive of connective tissue disorders, and these are supposed to arise because of a more intense autoimmune attack on the spinal cord cells. And later on, this is also likely to progress onto more severe cord atrophy in chronic cases. I hope you were able to appreciate these multiple discontinuous lesions, which are the bright spotty lesions, quite specific to connective tissue disorders with NMO. So in this article of NMOSD and connective tissue disorders, they have recommended that for a neurologist, when you see patients with NMOSD, do suspect with any history suggestive of connective tissue disorder, we need to screen for them. And also rheumatologists who are treating patients, known patients of SLE or Sjögren syndrome, if any patient develops symptoms of transverse myelitis, we need to check for NMO. If we don't send the aquaporin for antibody, we would never know if they have concomitant NMO or not. This is another study in which they have analyzed patients with aquaporin 4 positive with highly active NMOSD. So they have defined highly active NMOSD as patients who've had more than 2 relapses of NMOSD within 1 year. And they found that the presence of connective tissue disorder increased the odds ratio by 5.9 of patients having highly active NMOSD or more than 2 relapses in a year. Also elevated homocysteine levels and increased 24-hour IgG synthesis rate was associated with highly active NMOSD, but less so than connective tissue disorders. Also, in the second pie chart, if you can see, the presence of connective tissue disorder is much more significantly higher in those with highly active NMOSD. Crest-like lesions have been documented in NMO. The water flux impairments which occurred because of an aquaporin autoimmunity can predispose the patients to PRES. And this could be especially when they have BP fluctuations, and also the various treatments we give for NMO, like IVIGG, plasmapheresis. These cause rapid fluid shifts, which also can cause PRES-like lesions. So the aquaporin 4 channels, they are critical both in the development of cytotoxic edema and also the resolution of vasogenic edema. This is one of the large case reports of 12 patients with PRES in NMO patients, and this is excluding patients who were treated with rituximab who had PRES secondary to rituximab. So I hope you can appreciate the more posterior parieto-occipital and also atypical anterior PRES lesions. I'll also speak a little bit about uremic encephalopathy and the lentiform fork sign. As you can see, this is the lentiform fork seen in the basal ganglia cuts. The outer stem of the fork is formed by the external capsule. The stem is formed by the confluence of the internal capsule and the external capsule, and the middle part of the fork is divided into the internal medullary laminae and the external medullary laminae, which because of the putamen, globus pallidus internus and externus. This lentiform fork sign is not specific to uremic encephalopathy. It can occur with diabetes, methanol, ethanol poisoning, other organic acidemias, pyruvate dehydrogenase deficiency. Any metabolic acidosis can produce it, and also drugs are known to cause it, especially metformin. So these, especially if the condition is reversible, like uremic encephalopathy, repeat imaging after 2 to 3 months should show resolution of this. And in 6 weeks, there was a decrease in the lentiform fork sign in our patient. So from our case, we would like to point out certain learning points that NMOSD can present as a combination of any of the 6 core features. And our patients seem to have 5 of them right at the onset of her presentation. Severe pain can be the presenting feature of NMOSD and is a very important part of NMO. NMO lesions can mimic PRES lesions, and NMO and CTD are known to coexist, and when we find one, we need to search for the other. I would like to hand over the screen to Kulkarni sir.
Yeah. So the purpose of showing this case was for several points, like this patient had presented with a very unusual form of NMOSD where she had multiple core characteristics at onset. She had an underlying CTD, she had connective tissue disorder, she had pain, she had PRES-like lesions in the MRI. So these were various odd features in the patient who had a straightforward disease, which probably all of us are seeing. Can you just show the next slide, Dulari? Yeah. So there is no case in the literature which has shown so many clinical characteristics at presentation. And then, of course, this patient had 5 core clinical characteristics at onset. So whether more number of core characteristics at onset has any effect on prognosis, we do not know. We believe probably because she had so many characteristics at onset, probably her prognosis may be poorer. And as far as the literature which says that if you have an additional CTD, your prognosis is going to be bad. This lady had probably 5 core characteristics at onset, plus she had a CTD also. So prognosis seems to be really bad. And whether this has any bearing on treatment, Dr. Rajashri says that probably we would add something more than rituximab because thinking that it may be vasculitis. So not for the vasculitis, but probably for a poorer disease, whether we want to give more aggressive immunosuppression rather than just rituximab alone. This is a question, a point to ponder. We are discussing this with our rheumatologist also and going on to see what best we can offer to this lady. And as Dr. Dulari said, like highly active MS, now we have this new disease which is called a highly active NMO, where patient, if he or she has 2 relapses in a year, this is considered to be a highly active disease. And I'm sure like highly active MS, where we have aggressive immunosuppression or aggressive DMTs, which are available, unlike the first line therapy that we're using, probably for highly active NMO, we may come up with certain treatment options which may be really aggressive, more aggressive than the current treatment like rituximab, which we're using. I'm sure all of you know that there are 3 treatment options which have been approved for NMO in US by FDA, and one of them may come hit India in a year's time. So we may have more options as far as treatment of NMO is concerned, which may be available. And then there is a chance that we may start using combination of therapies as far as aggressive immunosuppression concerned in future.
Dr. Rahul?
Yes, sir.
Thank you for a wonderful feast. Okay.
Yep.
And with so many learning points. I just have one quick question. What was the renal diagnosis?
She was having dehydration, and then because of dehydration, she developed uremia. And then, of course, with hydration, it got corrected after some time.
Why I was asking this is, among the distribution of the aquaporin channels, apart from the brain, the distribution of the aquaporin channels was present in the renal tubules. So I just wanted to know whether there was any link between that two also, so that would make us a very rare combination of things.
Possible,
Secondly,
but then her renal parameters probably started improving before the immunotherapy was initiated.
Pardon?
The renal parameters started improving before the immunotherapy was initiated. So we believe it was more like a acute tubular necrosis, like what we get because of dehydration, the acute kidney shutdown.
This lentiform fork sign was classical.
Yep.
And involvement of even the external capsule, I was seeing some thing. And you will know that basically all the water channels in the brain has, the press was again an autonomic disbalance, which can again one of the very important manifestations of NMO. So in very beautiful, any postgraduate who has listened to this would understand the protein manifestations of aquaporin syndrome, starting from the medial thalamic. The medial thalamic syndrome, that can very closely mimic your encephalopathy, because the consciousness is rest on the consciousness is the nucleus responsible for the consciousness is all in the medial thalamic nucleus. So that would explain an encephalopathic feature also. And area post-prima syndrome is there, diencephalic involvement is there, long cord lesions, differing. Wonderful case. I should really congratulate you for a real feast of neurology for all the postgraduates. And not only that, the discussants were immaculate. And I should appreciate the entire team of boys. And I also take pride in Dr. Dulari. So, and Dr. Pujari, he also did a very beautiful job. So overall, I really thoroughly enjoyed this session. And my sincere thanks to Rahul. You have taken us into a really higher level of immunology. And I never knew that a few of these rarer things, which are combination of SS, the systemic sclerosis, C and all. I never knew. I should really thank you for highlighting that what was the importance of these various individual antibodies and where do they occur in combination. That was also one wonderful take-home point. Overall, thanks for a beautiful neurological feast for the day. Over to Dr. Shripad Pujari. My special congratulations for the thought-provoking questions you asked, and I really enjoyed your session. And my sincere and hearty congratulations to all the presenters and the discussants. Thank you. Thank you so much.
Thank you.
Over to Mr. Arun Chadda for.
Thank you, sir. Thank you very much. And today it's really a great day that we are the end of 16th session of Secrets of Neurology web series. The entire 16th session turned out to be very successful, and I, Arun Chadda, Associate Vice President on behalf of Intas Pharmaceutical, would like to pose a hearty vote of thanks to all the honorable delegates.
Dr. Rahul.
Yes,
Rahul.
Yeah, tell me.
And I tell you, the collections of all these episodes were really immaculate. And telling you, varied manifestations, and each institute has showpiece the most beautiful case. And I think
you must come up with a book of this. You and
I think so, because even the discussions, I think we will. What I thought we will well, during the NCon, we will just sit at that and then discuss of. We should have at least we should put it on all these cases. These collections would be even. I would tell you, it is no way inferior to the CPC collections of Massachusetts. I'm not joking. I'm telling you with all sincerity. Even this case which you have shown has so much of intricacies, and it's all worth. We should keep these collections, and no wonder that this meeting attracts so many overseas people also. And I am thankful for your show. Yes, over to Arun Chadda. Sorry for the interruption.
Thank you. No problem, sir. So first of all, I would like to thank our honorable course director, Dr. Sudhir Shah sir, and Dr. Lakshmi Narasimhan sir for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DMD students. And I would like to thank our young neurologists, Dr. Chinne and Dr. Shreya, for presenting the excellent, unique case. Further to this, I would like to thank the entire Dinanath Mangeshkar Hospital faculty, Dr. Dulari ma'am, for case discussion and the differential, and finally diagnose further to this. And further to this, I would like to thank to Dr. Rahul Kulkarni sir and Dr. Shripad Pujari sir, those who have really given insight of the unique case, and the entire presentation will be extremely helpful and informative to all the participants. Once again, thank you for your gracious presence, and it's being a pleasure being with all of you today. Thank you all for your patience, and I wish you all a very good night, and along with that, a very good happy Deepavali to all the participants and all the honorable presenters also. Wishing you a very happy Deepavali. And we will
very happy Diwali to all of you.
And we will meet on 26th November for our next session.
Thank you.
Thank you, sir. Thank you. Till then, stay safe and take care. Thank you, sir.
Thank you. Thank you. Take care. Thank you. Yeah. Okay.
Thank you, sir.
Thank you. Take care. Bye.